Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started.
Welcome, everyone. Welcome back to Healthcare Reform 2.0, season number 2. Tom, it's been almost 6 months since our last show, Serious as a Heart Attack. A lot's going on with your recovery, which wasn't as smooth as we projected it to be when we signed off last time.
That's for damn sure.
Had a lot of problems, and we're going to talk a little bit about that today. At the same time as you're going through the recovery, you made a major change in your life. You moved to this beautiful new home and remodeled it, and I must say your wife has done a fabulous job, probably without much of your help.
I just went along for the ride.
Yeah, and hopefully you didn't lift anything. But I wanted to expand a little bit on your experiences and even how a well-educated and informed healthcare consumer, which we are, just how difficult it can be to be your own advocate, what you have to watch out for, and the mistakes that occur every day in this healthcare quagmire.
Well, Tim, thanks, and it's good to be back. You know, we had started to do that show, Serious of a Heart Attack, because I was under the misimpression that I was going to be able to just move right back into doing everything I was doing before, and I felt pretty good. Didn't feel great at the time we did that show, but ran into a series of complications before the show, and those complications took a whole lot longer to repair and fix than I expected. Mm-hmm. I had 2 surgeries during that period. I had the second surgery, which was to repair an aneurysm in my femoral artery. They diagnosed it very short period of time from when I was in the hospital, as you know. But it took 5 weeks before I could actually get in the hospital to get the surgery because I was having complications from the heart attack with blood chemistry and blood levels that were scaring the anesthesiologist and raising the risk of brain death during surgery, which I thought was probably not the best use of my time. So the good news is I'm recovered. The bad news along the way was it just kept illustrating over and over again this key point, that healthcare is needlessly complicated today. We've built a system that's not a system. We have spent all this time trying to push the responsibility down on patients to make decisions. But whether you're an educated consumer or not, there's almost no way you can make a decision.
Right.
And I'll take a second to talk about one of the issues that came up. As you know, my total hospital bills for all of this at the invoice price was $1.2 million. That's $1.2 million, ladies and gentlemen. And I don't care, to tell you the truth. I don't care. I'm here. That's what it cost. Now, that's not what was reimbursed. What was actually paid was about $720,000, which is more than it normally would be for your average health care, because when you're in critical care, your reimbursement rate, instead of 22 cents on the dollar, is about 50 cents on the dollar. So they paid roughly half of the bills that I had. But some of those bills are a result of mistakes that were made in the process of treating me for my heart attack. Some of those mistakes derived out of equipment failure. Some of those mistakes derived out of the failure of people to effectively seal a wound correctly. There's a number of things. There was some medication-related problems that came up and caused me blood chemistry issues that took a while to diagnose. All of those things were charged back to me. And one of the most important things is we talk a lot about in-network and out-of-network, and that's all theoretically very good. But when you've died, as I did, and they have resuscitated you, and they have taken you in to start to remediate the problem in your heart, and the lab equipment at the hospital fails, Then the hospital itself arranges for a transfer of you to another hospital where they can resume treating you for your heart attack. Meanwhile, nobody at the hospital thinking I'm going to make it.
Right.
The hospital called a transport company and it was out of the network. Now, first off, no one said to my wife, I wasn't conscious, this is out of your network. Do you want me to get this?
Nor would anybody do that. This is a common problem, especially in these type of cases where it's a trauma case, an emergency case, things happen, you don't have time, and this out-of-network issue becomes an issue after the fact.
Exactly. And do you think if the physicians or the hospital administration went to my wife and said, just so you know, we're arranging transport, it's out of network, do you think in her mental state at that time,
No.
she would have been able to make a decision about that?
Of course not.
No. So what was the difference? Because they chose an out-of-network transport company. Instead of between $1,700 and $2,400 for the transport, list price, the out-of-network price was over $9,000. Now, inside secret, we didn't pay it. I didn't pay $9,000 for that transport. I told the insurance company we weren't going to pay for it. We weren't agreed to pay for it. Either they could go back to the hospital and bill the hospital because the cause of the transportation was a failure of their equipment, or they could go negotiate with the transport company. At the end, I don't know what was ever paid because nothing ever showed up in my EOB about who was paid, but we've heard nothing since. So I could go on for quite a long time about what has happened since to where we are today. The last thing I'll close on is a very good positive. One of the things that my insurance covers and most insurance covers is cardiac rehabilitation. Now, I couldn't start cardiac rehabilitation when I should have after the surgery because I had the problem with the aneurysm in the leg, and then I couldn't start it for 4 or 5 weeks after they repaired the aneurysm because I had the problem with the scar healing and closing up. So I started cardiac rehab about a month ago. And I will tell you, it's one of the best things that's come out of this. Going into cardiac rehab, they've gotten me back in good physical shape. I wasn't in horrible physical shape before. I was active. I felt pretty good, but nothing like I feel today. The effort of the people at cardiac rehab has taken me down 2 pant sizes and 28 pounds. Yep. And they have worked very heavily on improving my cardio, and I didn't think I had a cardio problem before, but the difference between then, before the heart attack, and now in my mental acuity and how I feel daily is astonishing. So
it's probably that broccoli you're eating every night too.
Yeah, probably.
Maybe carrots.
Probably.
I'm sure you changed your diet to something, but you didn't really have a bad diet to start with.
No, I didn't. Yeah. I ate fairly healthy. Right. It was astounding to get through this thing. It was very, very interesting experience, and it illustrated for me the depth of problems that exist in our existing healthcare non-system. Over the next couple of episodes, Tim and I are going to talk about a number of articles. Here's just a couple here. And they talk about how hospitals are trying to solve for the out-of-network problem. They talk about the need for patient advocacy. And as Tim knows, and many of you know, I've been advocating for what we call facilitators, which are a little bit of an expanded role over a patient advocate for over 10 years. And it's about time people are starting to see the need to do these things. But we're really still not addressing it, and we'll go through this article in a future episode, and we're going to explain why this doesn't even touch the surface about what it needs to be done. It's theoretically a good thing to say we're going to have a patient advocate, but if they don't empower the advocate the correct way, if they don't train the advocate in the correct way, and if they don't make advocacy something other than a free service provided by insurance companies, it's never going to do what it needs to do. And we've talked about that in past shows, and we'll talk about it again in the future. And then the last thing is this issue of price transparency. Right. And price transparency under the existing system is impossible. It's impossible. Telling a hospital to publish their costs for services is not doing anything because their costs for services are often not what they get paid. In fact, in 90% of the time, they're not what they're getting paid. They know they're getting paid less. So to put out that transport's $9,000 when the reimbursement should be $2,200 to $2,300 doesn't do the patient any good, because they're not comparing the cost that they have to pay or their insurer has to pay to the cost that is being advertised against someone else. So all that to say, we've got a lot to talk about, I think.
Yeah, we do. I want
this year.
to, and before we jump into that, because price transparency is the biggest joke of the terminology ever used. And so, folks, again, Tom's charges, list price 1.2, amount paid 700,000. That's on the high side for the things that you mentioned. Mm-hmm. So the dinner the other night, and the guy sitting next to me, we talked about healthcare, and he says, "Well, I had some bunions taken care of, and it was going to be $55,000." And I looked at him and said, "No, it's not. It's nothing even close to that." So the price transparency issue, if you see the charge masters and you see what these people are publishing, that's their list price. That's their retail, if you will, list price. It has nothing to do with what they get paid. Example, PET CT scan, we charge $5,900. Of average reimbursement's $1,200. And that's with the Medicare. It's also with the what we call the contractuals, the deals that we cut as a provider with insurance providers, insurance carriers. And no one will ever tell you what that number is. If they did, it'll go into what we're just about to segue into, the predatory nature of this business.
Exactly.
Yep. So with that, we're going to jump into Season 2's theme. And before I start, Tom, what is the most dangerous job in the world?
Commercial fishermen.
The deadliest catch, right?
The deadliest catch. Commercial fishermen. About 200 fishermen out of 100,000 die every year.
Yeah, one just did, the boat just capsized. I don't know if you saw that or not.
Yeah.
What's much more dangerous than that?
Getting health care.
Exactly.
And with getting health care today, about 400 people out of 100,000 are dying just getting health care. Prior to the implementation of the Affordable Care Act in 2013, when this study was done, the earlier study had it at about 268, 269 people per 100,000. Healthcare, since we started changing the nature of healthcare, and it's not just the Affordable Care Act that changed care. There's been a lot of things going about to change the way we deliver care for a lot of reasons that don't have anything really to do with improving outcomes. And even the things that were about improving outcomes have not improved outcomes. They've actually made healthcare more dangerous, because we look at healthcare in a very strange way, and we need to stop doing that.
It's the biggest trust equation in the world.
Exactly.
And if there is no credibility and empathy, then it kind of breaks down. So, off to the theme for Season 2. Dangerous, hostile, and predatory. Inside the American healthcare quagmire. So a quote from Money Driven Medicine, I've used it before, Maggie Meyer's book. And this is from Arnold Relman, MD. In all parts of the medical system, the providers of care see themselves as competing businesses, struggling to survive in a hostile economic climate, and they act accordingly. The predictable result is a fragmented, inefficient, and expensive systems. Market forces have splintered the U.S. healthcare system. In theory, free market competition should reduce the cost of the product. This is not the case in the U.S. healthcare marketplace. In this marketplace, supply leads demand around by the nose. So we have talked about the danger factor a number of times in our previous episodes, if you remember. We will bring this back to the discussion in more detail, as well as the hostile and predatory nature of the American healthcare business, beginning with the next episode, 1.2, a predatory and hostile economic healthcare environment. Tom, your thoughts on where we're going and some of the insights and your experience around these topics.
Well, Tim, this is really important. And as you said at the outset, part of this has been stimulated by my experience in the healthcare system as it is today, and really being able to drill down further on where some of these problems are. Healthcare today is driven by a series of things that have evolved over the last 45 or 50 years as we moved from indemnity-based coverage to the idea of HMOs and then PPOs and then other forms of the same thing with, fee-for-service, managed care, all these other things. We've tried to come up with ways to fix problems that were seen at the time. We talked today, as you and I have talked before, about patient-centered care. The reality is not much of the care that's being delivered is truly patient-centered. It's patient-centered if you're within an institution. If you're within an organization or a network, yes, it's patient-centered. But if you have to go outside of the network to get a transport or to get a specialist that is very, very good at the specific problem that you're having, it falls apart. There is no way. My GP can get my medical record if I go to hospital A. But if I'm in hospital B, like I was after my heart problem, but while they were waiting to remediate it and complete the surgery, he can't see their information. He's not part of that hospital, so he doesn't get that data. He's got this EMR system over there. That one isn't talking to him, and vice versa. When he's doing blood tests, those doctors over there, my cardiologist and others, aren't really getting that data in the EMR. They're getting it electronically sent to them, and then they have to put it in their EMR. Assumingly, some person in the organization has to push that stuff over into my record, which means it's delayed.
And for that to happen, there has to be two things in place. One, a business associates agreement, or two, your signature permission allowing that to happen.
Exactly, because of HIPAA, which we've talked in earlier episodes. We need to work on focusing at repairing the system so those kind of things, those kind of structures, those kind of situations don't exist. So overall, my comment on this is healthcare is getting more dangerous because the non-system we've built is getting more complicated, more troublesome, and it's taking the things that used to work, throwing them out and expecting something new to work within a system that isn't a system in the first place. The new things we're doing, whether it's technology, systematics, change in practice models, by and large are not working when it comes down to the quality of patient care, outcome, and price.
So, ladies and gentlemen, when I ran this particular theme by a few people, a number of folks came to me and said, "That's pretty drastic. I didn't understand that. What are you talking about?" Well, I'll give you that if all you do is go to your primary care physician, you got a sore throat, you got minor stuff going on, and they can take care of it. You don't see any of this stuff, right?
Right.
But just wait till a chronic illness happens. Wait till a traumatic event happens. Unfortunately, God forbid, an accident or something like that. Then the whole world goes upside down and changes. And you've experienced that. We've all experienced that. So we don't want to scare everybody, but we want to help you get a sense of what it's really like if you're in the provider side and in some cases the supplier side of this hospital quagmire that we're in the United States. So we're going to start there, and we're going to work through it over the course of the next few months.
Well, we'll be back in episode 2 in a few days and be glad to talk to you about these kind of problems and start to work through not only what the problems are, but how we think there's solutions to all of them. Right. And that we can get an effective healthcare system that we can all use. But again, the last point, which was brought up by a couple of viewers and listeners last year in emails to us, what we're saying to you is giving a basis for you to be able to go out and help everybody make a change. Congress isn't going to do it. The doctors aren't going to do it. The hospital systems aren't going to do it. The insurers aren't going to do it because they're all preying on each other to find a way for their business to make margin. We need to do it as the patient, as the participant in the system. We need to do it in order to get the government to really do it, because today we're sitting at a standstill with a mess that's broken and getting worse every day. So with that happy note, we'll see you soon. Thanks.
Thank you.
You've been listening to Health Reform 2.0 with your hosts Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.